A very good morning to all of you, and all are warmly welcome to the GMO Academic Cow program. Today's lecture is on www.lab-test, who, when, and which for common laboratory testings. That is all about laboratory testings. So we have invited Dr. Tushara Hewageegana, who is the consultant chemical pathologist at Teaching Hospital Anuradhapura, who also is a visiting lecturer and examiner at Rajarata Medical Faculty and also at the Postgraduate Institute of Medicine. Dr. Hewageegana obtained his MBBS from University of Colombo with second-class honors and diploma in pathology, followed by MD in chemical pathology in 2011. So let me warmly welcome Dr. Tushara Hewageegana to the GMO Academic Cow program today. And over to you, Dr. Tushara.
Okay, thank you very much for that kind introduction. And thanking the Government Medical Officers Association for giving me this great opportunity. I will straight away get on to my task. www.lab-test, who, when, and which for common laboratory investigations. Right, I am not a wizard to discuss all the lab investigations under the sun within a period of 1 hour. So I will be mainly concentrating on the investigations in diabetes, dyslipidemia, and thyroid. Right, a 46-year-old man in a general medical checkup was found to have a fasting plasma glucose level of 128 milligrams per deciliter. What is the interpretation? And what is the next step in his investigations? I will give you a few seconds to think. Okay, we'll move to the next slide, and first we'll discuss fasting plasma glucose. Fasting plasma glucose, blood is obtained with a fast of 10 to 12 hours, and blood should be collected into a what you call S tube, which contain sodium fluoride and potassium citrate. And how do you interpret this fasting plasma glucose results? There are two commonly used guidelines. One is the WHO, other one is the American Diabetic Association guideline. So out of the two, what is more relevant and more applicable to the Asians is the WHO one. So I am showing you the interpretation given in the WHO classification. So according to this WHO guideline, a fasting plasma glucose level equal or below 110 milligrams per deciliter is non-diabetic. Anything between 111 to 125 is impaired fasting glucose. Equal and above 126 milligrams per deciliter is categorized as diabetes. Right. Remember, this fasting plasma glucose is one of the most standardized tests in the world. So therefore, your cutoff value does not depend on the lab. From which lab you obtain your results. These are the cutoff values. Right. So now you know fasting plasma glucose equal or above 126 is diabetes, and your patient is having a value of 128 milligrams per deciliter. And I have asked another question. Are you going to label him as diabetic? I will give you a few seconds to think. Okay, let me move to the next slide and see what diabetes is. So diabetes mellitus is diagnosed with certain criterions. If the fasting plasma glucose is equal or above 126, and if the 75 gram oral glucose tolerance test giving a second hour value equal or above 200 milligrams per deciliter, or a random plasma glucose value equal or above 200 milligrams per deciliter with classical symptoms. So first two, fasting and 2-hour OGTT, you don't have to have symptoms. But if you go for random plasma glucose, the patient should be having classical symptoms of hyperglycemia, which include polyuria, polydipsia, unexplained weight loss. And for none of these glucose assays, glucometer value is not acceptable. So it should be a value that is obtained from a laboratory. HbA1c is also now used or recommended to diagnose diabetes mellitus. If the value is equal or above 6.5, it is diagnostic of diabetes mellitus. And like your glucoses, HbA1c is also one of the most standardized tests, and therefore the cutoff values do not depend on the lab. From where you obtain the values, the same cutoff point. Right. Let's move to the next slide. The diagnosis should be confirmed by repeating the same test with a new blood sample or by another test, except in hyperglycemic crisis, like with diabetic ketoacidosis, and also in the presence of classical symptoms of hyperglycemia. So except in those two conditions, you have to repeat the tests using another method or by another sample. So if I get back to you to the previous question, okay, before that, if you see discordant results from two different tests, it should be repeated. Right. So if I take you back to the case under discussion, a 46-year-old man in a general medical checkup had a fasting plasma glucose level of 128 milligrams per deciliter. So he's above the cutoff point, there's no question. But are you going to label him as diabetic? No, because you have to confirm that by a second test. Suppose you have confirmed that your patient is having diabetes, and now you have to follow the patient up for his lifetime. And how you are going to do this? Fasting plasma glucose monthly, HbA1c once in 3 months until you obtain the optimal glycemic control. And once you obtain that optimal control, you have to do it in every 6 months at least, right? So better if you can do it in every 3 months, but at least in every 6 months. And also your patient need urine albumin to creatinine ratio annually and lipid profile annually. Right, now a bit of a word about this urine albumin, right? So previously there was a test called microalbumin, which is no longer in use now. So now if you request microalbumin, still we will be doing the same urine albumin. So albumin and microalbumin, they mean the same nowadays. So you don't have to request microalbumin, just request albumin. Right. So in a patient with diabetes who is in the follow-up, the most important question is whether you have achieved the glycemic control. The recommended controlled plasma glucose level is 80 to 130 milligrams per deciliter and a HbA1c level below 7%. And the 2-hour postprandial plasma glucose level should be below 180 milligrams per deciliter. Right. Now a commonly asked question is, how do you calculate these 2 hours? You have to instruct the patient when to come to the lab to give blood after the meal. People ask when to calculate whether these 2 hours starting from the first bolus of the diet or after the end of the meal. So the answer is the patient has to calculate these 2 hours from the first bolus, and the meal has to be completed within 15 minutes. Okay, still we are with the same patient. So your patient is having a fasting plasma glucose level of 140, and you know the target value for a good glycemic control is between 80 to 130. And what are you going to do in this patient? I will give you a few seconds to think. Right, now if the patient is stable and if he or she is not a hospitalized patient, then you can try lifestyle modifications for control this 140, which is not very high. But if he is in an acute illness and the blood glucose level is persistently higher than 140, then this patient needs adjustment of his pharmacological treatment. And with critical illnesses, it is recommended to maintain the blood glucose level between 140 to 180, while the lower limit is preferred. Right. A 46-year-old diabetic awaiting an elective surgery, and his fasting plasma glucose is 140, just above the accepted target level for a good control. What are you going to do here? I will give you a few seconds to think. Right, the patient is awaiting a elective surgery. So you got to check his long-term glycemic control with the HbA1c. Right, you have done it and your value is 8%. As I mentioned, a good glycemic control is below 7%. So he's just above that. And what are you going to do? I will give you a few seconds to think. Okay, let's move to the next slide. Elective surgery should best be postponed whenever possible if the glycemic control is poor, as indicated by a HbA1c level of equal and above 9%. And the capillary glucose level should be kept between 80 to 180 during the perioperative period. So you can see that HbA1c level of 8 does not warrant postponing the elective surgery in this patient. Right. I mentioned you that the target HbA1c level is 7%, which indicate a good glycemic control. But that is not a universal theory. It is not a universal cutoff point. If your patient is young, having new onset of diabetes, and if he is motivated without comorbidities, he is going to get benefit from a strict glycemic control. So these situations, your glycemic control should be a HbA1c level below 6.5. Whereas coming to old people with comorbidities, trying to achieve a good glycemic control around 7 or 6.5 is dangerous. There's a good chance that your patient go into hypoglycemia. So these people, the target HbA1c level is 8%. Diabetic is a common disorder. It is said that the prevalence of diabetes in Sri Lanka is around 1 in 20 of adults. So therefore, it's worth screening the disease. And screening is recommended in individuals with one or more major risk factors. So let's see what are these major risk factors. Age equal or above 45. Overweight with a body mass index equal or above 26 kilograms per meter square. Right. So remember, the European standard for overweight is 25 body mass index, but this has been lowered to 23 in Sri Lanka. So in our country, body mass index of 23 and above is considered as overweight. Family history of diabetes, that is type 2 diabetes in parents or siblings. Habitual physical inactivity. Hypertension, of course, is not a risk factor for diabetes, but it's a common association and also a comorbid factor. For these reasons, these hypertensives also should be screened for diabetes. HDL below 35 and or triglyceride level above 250 milligrams per deciliter should also warrant screening for diabetes mellitus. History of vascular disorders, coronary artery disease, cerebrovascular diseases, and peripheral vascular disorders. They also warrant screening for diabetes. History of gestational diabetes mellitus or delivering a baby weighing 3.5 kilograms. Right. Again, the European standards and the American standards is a baby weighing 4 kilograms is considered as a large baby, but we have brought it down to 3.5 in Sri Lanka. So delivering a baby weighing above 3.5 kilograms warrant screening for diabetes. Polycystic ovarian disease is considered as a high risk for diabetes, and they should also be screened for diabetes. Acanthosis nigricans, if you see, that indicate hyperinsulinemia, most probably due to insulin resistance, and catch that patient and screen for diabetes. So what are the screening methods for diabetes? Fasting plasma glucose is the recommended test for screening. If the patient is not very happy to be in fasting and giving blood, random plasma glucose is the alternative. When plasma glucose value, that is the laboratory values, is unavailable, capillary glucose, that is the glucometer value, is recommended and accepted. Right, I have already mentioned that a fasting plasma glucose level equal and below 110 is non-diabetic. A value equal and above 126 is diabetic. Then what about the in-between value, 111 and 125? This value is considered as impaired fasting glucose, and it is pre-diabetic. And these patients should be assessed with oral glucose tolerance test and HbA1c. Right, what is impaired fasting glucose? If the fasting plasma glucose value is in between 111 and 125, or oral glucose tolerance test with the second hour value between 141 to 199, and if your HbA1c value is between 5.6 to 6.4%, that accounts for pre-diabetic, and these patients need follow-up with annual fasting plasma glucoses, because these patients carry a risk of diabetes mellitus in the future. But unlike diabetes, this can be reverted back to normal. So it's good if you can catch the patient at this level, at pre-diabetic level, and do the necessary things so that you convert him back to normal. Okay, so far in this presentation I mentioned about the oral glucose tolerance test on several occasions. So now I'm going to talk about oral glucose tolerance test in details. The indications. One, you already know, impaired fasting glucose should be assessed with the 2-hour value of the OGTT. It is also done in the screening for maternal diabetes, and also in the suspicion of diabetes when the fasting plasma glucose is normal. Sometimes your patients have a normal fasting plasma glucose. That is because within that 10 to 12 hours fast, he clears his postprandial glucose from his blood and his fasting is normal. However, that patient is unable to clear his glycemic postprandial glycemia within 2 hours of a meal. So that patient can be caught only if you do OGTT second hour value. So this is why even with the normal fasting plasma glucose, you are supposed to do OGTT if the patient is still suspected to have diabetes. How do you do OGTT? Put the patient on an unrestricted carbohydrate diet and activity for 3 days prior to the test. Like in any other fasting plasma glucoses, here also you need 10 to 12 hour fast. And better you stop all the possible medications on the day of the test. Smoking should be avoided and patient should be seated throughout the test. OGTT, as you know, there is a fasting value and then glucose is given and another sample is taken 2 hours later. So the patient might ask, okay, I will give the fasting value, I will give blood for the fasting blood sugar, then I will have some shopping and come in 2 hours time. No, it is not accepted. Patient should be seated throughout the test. 75 grams of glucose is dissolved in 300 ml of water and that should be taken within 5 minutes. In children, you can't give 75 grams, so the amount of glucose you are giving should be adjusted for the body weight, and it is 1.75 grams of glucose per kilogram body weight in children, up to a maximum of 75 grams. Right. Now, once you do your OGTT, oral glucose tolerance test, you have to interpret the same. Right. As I mentioned earlier, OGTT has 2 values, the fasting and the second hour value. Now look at the interpretation of the fasting values. Normal is equal or less than 110. Between 111 to 125 is impaired fasting glucose. Equal or above 126 is diabetes. So it is just like you interpret your ordinary fasting plasma glucose. There's no difference when it comes to the OGTT. It is the same fasting plasma glucose. In addition, you have the second hour value. How do you interpret? The normal or non-diabetic is when it is below 140, equal or below 140 milligrams per deciliter. It is diabetic if the second hour value is equal or above 200 milligrams per deciliter. Then there's a new entity. If it is in between these two, 141 to 199, that is impaired glucose tolerance. I mentioned about HbA1c on several occasions so far in this presentation. So let's see what this HbA1c is. It is non-enzymatic addition of glucose molecule to the N-terminal beta chain of adult hemoglobin A, adult hemoglobin or HbA, and it indicates the glycemic control or the average lifespan of a red cell, which is around 120 days. So your HbA1c is going to tell you the glycemic control of your patient for the last 120 days. The non-diabetic HbA1c is when it is equal and below 5.6. Anything between 5.7 to 6.4 is pre-diabetic. If it is equal or above 6.5, that is diabetes. So this is how you interpret, and as I mentioned earlier, HbA1c is well standardized, so these cutoff points should not vary from one lab to the other. However, there are problems in the interpretation of your HbA1c. You might get falsely high results with iron deficiency anemia, where the average lifespan of a red cell is higher than 120 days. With uremia, what happened? Certain toxic agents that accumulate in renal failure binds to hemoglobin moiety, and that interfere with our laboratory assay, giving falsely high results. You can have falsely low results with hemoglobinopathies. That is because the average lifespan of a red cell of your patient is below 120. If your patient has had a blood transfusion within 3 months, your test is unreliable because he is running somebody else's blood. Right, so diabetes in a non-pregnant is one thing, and diabetes in pregnant is another one. So let's see the investigations in maternal diabetes. Universal screening of all non-diabetic pregnant mothers should be screened for diabetes before the 12th week of gestation, except there are 2 conditions where you don't have to investigate or screen the pregnant ladies for diabetes. I will give you a few seconds to think and get the answer. So non-diabetics, you don't have to screen, and non-impaired glucose tolerance, that is a patient with a fasting plasma glucose level between 111 to 125. So this patient fall into diabetes when they get pregnant. So there's no reason for you to screen these two for diabetes when they get pregnant. But everybody else should be screened for diabetes during the first trimester of pregnancy, because being South Asians, we are a high risk nation for diabetes, and your pregnancy is diabetogenic. So if your screening is negative during the first trimester, during the first 12 weeks of gestation, what are you going to do? You have to do the rescreening during the second trimester of pregnancy, around 24 to 28th week of gestation. The College of Obstetricians and Gynecologists of Sri Lanka now recommend a non-fasting OGTT, so which is more convenient to the patient. There's no need of fast. So what you do is you give 75 grams of glucose load to a non-fasting pregnant lady and obtain only the second hour value. So there's no fasting value for this non-fasting OGTT. If the second hour value plasma glucose is equal or below 140, that exclude maternal diabetes. If the value is equal or above 140, that is maternal diabetes. 2-hour ppbs as a screening for maternal diabetes is also recommended by the College of Obstetricians and Gynecologists in Sri Lanka. So it's recommended if the standard one-stage non-fasting OGTT is not feasible. For an example, patient is having vomiting or nausea and has a particular dislike to drink this glucose solution. So these patients, our College of Obstetricians have recommended the second hour value after a meal, that is 2-hour ppbs. And remember, it should always be after a major meal, right? So that means your patient cannot have a small snack and come and give blood for 2-hour ppbs. It should be one of the 3 major meals. And if the glucose value is equal or above 120, that means this patient needs the standard oral glucose tolerance test. How do you diagnose maternal diabetes? If you go by the standard OGTT, that is 75 grams in a fasting patient, a fasting level above 92 milligrams per deciliter. If you do the 1 hour value, if it is above 120, and the second hour value above 153. So you can see that the values are totally different from the non-fasting, from a non-pregnant patient. If you do your OGTT during the first trimester of pregnancy, early pregnancy, the second hour value in the OGTT is 140 and above is diabetic, right? So there's a difference between the second hour value depending on the stage of pregnancy you do this test. These tests are not recommended as screening methods or for diagnostic tests for maternal diabetes by the College of Obstetricians and Gynecologists in Sri Lanka. So fasting plasma glucose, they don't recommend. 50 gram glucose challenge test, HbA1c, urine for reducing agents. So these are not recommended by the College of Obstetricians and Gynecologists in Sri Lanka. Coming to blood sugar series, which is done after hyperglycemia is confirmed in pregnancy. So you have to request BSS or blood sugar series only in non-maternal diabetics. Plasma glucose, plasma glucose is obtained pre-meal, which is 30 minutes before the meal, and post-meal, which is 2 hours after a meal. So, as you have 3 major meals, altogether you are having 6 samples. How often you should do your BSS? That of course depend on the stage of your pregnancy. Early pregnancy, it should be done 4 weekly, and late pregnancy in the 3rd trimester, it is recommended to be done in every 2 weeks. In the blood sugar series, your target glucose level for a pre-meal is between 90 to 100. Post-meal value should be below 120. As I mentioned earlier, fasting plasma glucose is not recommended by the College of Obstetricians and Gynecologists. However, the pre-meal for the breakfast, pre-breakfast is invariably a fasting one, and the fasting level should be interpreted as that. It should be between 70 to 90. Do you do HbA1c in maternal diabetic? The answer is it can be done and is recommended to be done only during 1st trimester of pregnancy. But after the 1st trimester, it is not recommended, and a good glycemic control during the 1st trimester is considered as below 6.1%. Right. So remember, non-pregnant, your good glycemic control is below 7%, but for pregnancy, you can see the values are different. Right. So having discussed the glucoses and investigations in diabetes, we'll come to the lipid profile, for which you need a fasting sample with a fast of 12 to 14 hours. But if you go for total cholesterol only, there's no need of a fast. Right? In the components of your lipid profile, it is the triglyceride that is affected by the fast. None of your cholesterols are affected by a fast, so total cholesterol you can do without a fast. The lipid profile include total cholesterol, LDL, HDL, triglyceride, and a good laboratory now used to give what you call the non-HDL cholesterol, and also the total cholesterol to HDL ratio. So these are the components of a routine lipid profile. In whom you should have a lipid profile? Vascular diseases, coronary artery, cerebral vascular disorders, peripheral vascular disorders, diabetes, family history or clinical evidence of hyperlipidemias. Adults about 20 years should have a lipid profile in every 5 years, and also you can do it as a general health screening. How do you interpret a lipid profile once the results are available? Actually, it is based on the individual risk. There is a risk stratification. So first, what you have to do is to set the LDL goal. So that is how much LDL you are going to achieve in this patient, followed by the triglyceride goal, how much triglyceride you can have in this patient. So let's have this in detail. I mentioned about the risk stratification, and there is an entity called coronary heart disease risk equivalent. So if you are having any of these things, it is like you are having a coronary heart disease. So they include diabetes, established coronary heart disease, abdominal aortic aneurysms, symptomatic carotid arterial disease, and peripheral arterial disease. So if you are having any of these, it's like having a coronary heart disease. So these are known as coronary heart disease risk equivalents. Apart from this coronary heart disease risk equivalents, we have other risk factors, other major risk factors, which include cigarette smoking, blood pressure, low HDL in men below 40, in women below 50, family history of premature coronary heart disease, and age above 45 for men and 55 for women. So these are the risk factors other than coronary heart disease risk equivalents. Now let's see how do you apply this to your patient. So if your patient is having a coronary heart disease risk equivalent, your LDL goal is less than 100 milligrams per deciliter, right? So that means if you are having any of these, your LDL should be below 100. Sometimes back, we did not have good anti-lipidemic drugs. But now, of course, we have very potent drugs. So now the recommendation is better if you can go below 70. So LDL 70 or below for coronary heart disease risk equivalents. And what if you are having any of these major risk factors which do not amount to coronary heart disease risk equivalents? If you are having 2 or more risk factors, you can have a LDL of 130 or below, right? So your LDL goal in these patients should be less than 130. And if you are having any of these major risk factors not amounted to coronary heart disease risk equivalents, you can have an LDL level up to 160. Anything above that you have to treat and get your LDL back to 160 or below. So here you can see that anybody without any risk, the maximum LDL you can have is 160. So anything above that you have to treat. And as you know, your HDL, high density lipoprotein cholesterol, is a negative risk factor. The higher the HDL, lower the risk. So if you are having an HDL above 60, you can remove one of those risk factors from the total. So that means if you count 2 risk factors in your patient who is having HDL of 6, then he come to the below category. He is having only 1 risk factor because you have removed 1 risk factor for his higher HDL. Once you achieve your LDL, you can target his triglyceride levels. However, if the triglyceride level is above 500 milligrams per deciliter, that is a risk factor for acute pancreatitis, a life-threatening condition, a medical emergency. So you have to achieve the triglyceride goal first. If your triglyceride level is above 500, regardless of your LDL. Triglyceride is also a risk factor for coronary heart diseases. It's an independent risk factor, which means you are perfectly normal except for a high triglyceride, still you are having a risk of coronary heart diseases. So triglyceride level between 200 to 149 may need drugs after achieving the LDL goal. So the point is, anything above 500 you immediately treat to prevent acute pancreatitis. Anything between 200 to 149 you first treat your LDL, then you can come and treat your triglyceride later. Right, as you know, statins are the most commonly used drugs in dyslipidemia. And how do you start or how do you treat with statins in a dyslipidemic patient? So before starting statins, you have to do certain investigations. Fasting plasma glucose or HbA1c. Serum creatinine with the EGFR to exclude chronic kidney disease, which is a comorbid factor in dyslipidemics. ALT, because your statins are hepatotoxic, and TSH, because hypothyroidism itself can cause dyslipidemia. And also, if you treat an hypothyroidic patient without controlling it with statins, it may be fatal. I will come to that later. And baseline creatine kinase is not indicated unless the patient is having symptoms related to muscle. Unless the patient is having myalgia, you don't have to routinely do a baseline creatine kinase value. Do not start statins in uncontrolled hypothyroidism because of two reasons. One is, once you control your hypothyroidism, that itself will correct dyslipidemia in some of your patients. Second thing is, statins in uncontrolled hypothyroidism can cause massive rhabdomyolysis, which can even be fatal. ALT above 3 times the upper normal warrants not treating with statins. Creatine kinase, if above 5 times the upper normal, again do not start statins. Okay, once you start statins, you have to follow the patient up with ALT doing at 3 months of starting statins and 12 months of starting statins. And after 1 year of statins, you don't have to do ALT routinely unless the patient is having symptoms of a liver disease. So once you start your statins, a lipid profile should be done in 3 months. And also, if you have changed your drug or if you have changed your dose, you have to repeat your lipid profile in 3 months and see, and thereafter you are doing your lipid profile annually. Creatine kinase is not indicated during follow-up unless the patient complains of myalgia. So if the patient is on statins and on the follow-up, you check whether you have achieved your LDL goal and the triglyceride goal, which we have already discussed. Apart from that, you have to check the non-HDL cholesterol. Right? I mentioned that some of the laboratories, particularly the good ones, now they report non-HDL cholesterol. If they have not reported non-HDL cholesterol, still you can calculate that. You subtract HDL from the total cholesterol. that include non-HDL cholesterol. And non-HDL cholesterol should be reduced by 40% or more to say that you have reduced your lipids. Statins are diabetogenic. But if you see new onset of diabetes in a follow-up patient who is on statins, it doesn't warrant stopping statins. Still you can continue your statins. With that, I come to thyroid functions, which include TSH, free T4 and free T3. And I have asked a question, which test out of these three would you do in hypothyroidism and hyperthyroidism? I will give you a few seconds to think. Okay, move to the next slide. Hypothyroidism, obviously TSH. TSH is elevated. So the analyte that is elevated is more sensitive to test the condition. And hyperthyroidism, of course, your TSH is suppressed. Yet, it is the most sensitive and specific test for hyperthyroidism. Right? However, if you do your TSH with free T4, it increases the diagnostic accuracy. Right? So I would recommend TSH if you suspect hypothyroidism, and I don't mind if you combine TSH and free T4 in a patient who is suspected hyperthyroidism. And your free T3 is not required unless you suspect T3 toxicosis. So most patients, you don't need free T3. If an abnormal thyroid function report is not compatible with your clinical presentation, you got to repeat that. Somebody who is on thyroxine is followed up for life, and you have to check your TSH in 4 weeks after starting your thyroxine or after adjustment of the dose. And your T4 and even T3 is not required in most occasions. So you have to maintain your TSH in the normal range during the follow-up, and once your TSH is stable, you can do TSH annually. TSH has a diurnal variation, which means if you do it in the morning and in the afternoon or evening in the same patients, your values may be different. So therefore, we recommend you to do the TSH at a fixed time. So if you had your TSH in the morning previously, next time also you better have your TSH in the morning. And blood test for TSH and even for free T4 for that matter is taken regardless of the time of the last dose of thyroxine. So don't worry about the dose of thyroxine. Regardless of the timing, you obtain your blood at a fixed time. However, your thyroxine should be taken 60 minutes before the breakfast, right? So your patient has to take thyroxine empty stomach. Otherwise, it will impair thyroxine absorption, right? So if you see a patient whose hypothyroidism is not under control, despite of good compliance, always ask, how does he take this drug, right? So after taking the drug, his stomach should be empty at least for 60 minutes. Okay, these are my references. And if you have any questions, I can take it now.
Thank you very much, Dr. Tushara Hewageegana, for that interesting and even very informative lecture. It was absolutely simplified and it was very easy to understand. And we have several questions received. First question is, how do we interpret non-fasting lipid profile? How reliable it is?
Okay, non-fasting lipid profile is now frequently requested. Non-fasting one is easy. You don't have to keep the patient fasting. And as I mentioned previously, out of the components of your lipid profile, it is the triglyceride that is affected. And your cholesterol is unaffected by your diet. However, your LDL, low density lipoprotein, LDL, is often calculated. And this calculation is based on your triglycerides. So therefore, non-fasting lipid profile might have a falsely high LDL level. Right, so what I recommend is, if your lab is doing direct LDL, right? So before I give the answer, let me little bit explain this. LDL often calculated, but some laboratories, they have directly measured LDL. So if your lab is directly measuring LDL, whether you are fasting or not will not affect the cholesterols and LDL. However, the calculated LDL is falsely high in non-fasting samples.
Thank you very much for that answer, sir. And the second question is, when it is the patient has come to the stable levels regarding TSH, is it enough to test the patient annually?
That of course depend on the condition of the patient. If the patient is stable, yes, TSH annual is sufficient. Right? You have to do more frequently depending on the clinical condition. If you see that the patient is toxic while on thyroxine, thyroxine, and if the patient is hypothyroidic while on thyroxine, you have to do then and there, right? So if the patient is stable, annual TSH is sufficient.
The next question is about thyroid status during pregnancy.
Yeah.
What is the most reliable test to monitor thyroid status during pregnancy?
Yeah, it's TSH is the recommended test, but TSH should be interpreted against the pregnancy related reference interval, which is different from the non-pregnant values. Okay, so I recommend you to ask from your lab what is the pregnancy TSH value for that particular lab and interpret that TSH according to the laboratory reference interval.
And the next question is, what are the main lab parameters that should be shown in patient health record? Example, LDL, total cholesterol.
Okay, right. As I mentioned earlier, we set the LDL goal for most of your patients. So LDL and triglyceride should be the one that is mentioned.
So, I want to ask another question, because that usually they say this carbs increase the triglyceride.
Which one increase?
Carbohydrates increase the triglyceride. Someone is taking regular items of rice, frequent rice intake, it can increase the triglyceride and it can affect the LDL.
Well, I would answer like this. Okay, the question is excess carbohydrate, whether it affect the lipid profile. The answer is yes. Out of all your cholesterols, only 20% is endogenous, only 20% is exogenous. So you absorb only 20%, out of all your cholesterols, 20% is the fraction that you have absorbed from the diet. So nearly 80% is made inside your body. So that is made with excess carbohydrates. So the more you eat, there is a higher chance of making more and more cholesterol. And triglyceride, of course, is mainly affected by the lipids in the diet rather than carbohydrates.
Thank you very much. And the next question is how we can prescribe thyroxine to a pregnant woman.
That is, of course, a bit of a clinical question. I think what you have to achieve is a normal TSH level, right? So I can't comment. I'm not going to comment on the dose and other things, but your target should be a normal TSH. And again, let me emphasize that it should be the pregnancy reference interval, right? The pregnancy TSH level is quite different from the non-pregnant value.
Thank you. And the next question is, can we go by normal references, that is fasting reference range, for non-fasting lipid profile as well?
Again, I didn't understand the question.
Can we go by the normal fasting reference ranges for the non-fasting lipid profile as well? The reference
Yes,
range.
yes. It's not actually a reference range, it's the cutoff value. It's the same cutoff value that you use, whether it is non-fasting or fasting. However, you keep in your mind that if the LDL is calculated and if you have done a non-fasting lipid profile, your LDL level might be falsely high.
Can you explain the fasting blood sugar? When we take the fasting blood sugar, fasting time for Sri Lanka?
Yeah, it's a good question. If you go through these guidelines, they will tell you a fasting period of 8 to 14 hours, right? A wide period, 8 to 14 hours. But in our practice, what we have seen is the Sri Lankans, they fail to get rid of the postprandial effect within a period of 8 hours, right? So if you do fasting plasma glucose 8 hours after a fast, you might get a falsely high value. So what I recommend is you better go for 10 to 12 hours, right? I totally agree that 8 to 14 hours is given in the guidelines, but for practical reasons, I recommend 10 to 12 hours in Sri Lankans.
And there's another question coming in. How to interpret thyroid function test in critical illness?
Yeah, critical illnesses, my advice is please don't do thyroid functions. Right? So it's very difficult to interpret, right? So if you do, we will be in real trouble. You also will be in real trouble because sometimes you will see a thyrotoxic feature, sometimes you will see a hypothyroidic feature, right? This is known as sick euthyroid syndrome, right? Sick euthyroid syndrome. So don't do thyroxine levels or TSH in a critically ill patient.
Thank you very much once again for Dr. Tushari Hewageegana for joining us today to the Academic Hour program, and hope to join you in another 2 weeks' time. Have a good day.